hospitalization. And then a couple of months, hopefully I'll go back to Norfolk and see patients. All right, so that's me. Any question for me? Okay, let's go through this. Already did the introduction. So we're going to go through 3 chapters of the emergency ward surgery, 5th edition. They're going to talk, the chapters that talk about the head injury, like how to perform surgery, right? You guys not going to learn how to perform surgery here. We're just going to go through the most common seen questions and information on the test. That's it. It's pretty much what we're going to cover. If you want to dig more into it, you can go into the chapters and read them yourself. In fact, for chapter 4, I think it's for the aeromedical evacuation, you might want to read that because I put some questions here and I purposely did not put the answers. We tend to remember more those questions that we've researched than the ones that just presented to us. Scientifically proved. I read it in Facebook, Twitter. All right. So, neurosurgical damage control, right? Once you have head trauma, what are you gonna do? Intracranial pressure, you want to control that. Burn holes, right? You guys heard of that? Burn holes before? There's some space between your brain and your skull, really tight, you're bleeding, cause pressure, damage the brain. Cerebral blood flow pressure, right? Make sure there's no clots, there's anything going on, there's oxygenation to the blood, and prevent secondary cerebral injury from hypoxia. If you lose oxygen to your brain dies. Hypertension. So if there's not enough pressure in your body, blood is not going to make it all the way up to your brain. And hyperthermia, right? Hyperthermia. That's opposite of hypothermia. Think about it this way, that if you build a lot of pressure, what does it produce? Heat, right? All right. So you might see a question in the exam that says, all of this are part of the neurological damage control except, and then just throw another option there for you to throw you off. All right, know the type of combat head injuries. Blunt, close head injury, penetrating. There's 3 types of penetrating, right? Fragments, gunshot wound, and guttering. I had to look up what a guttering was, right? It was like everything I found about guttering, it was just the gutters from the houses, but it's more like a fragmented skull floating in blood, pretty much. And then primary blast, overpressure, central nervous system injuries. I'll tell you a story, but let's just go through it. All right, classification of head injuries, right? Open, common sense. Just know that it's common in combat injuries versus civilian trauma. Close, which goes back to a blunt trauma and blast injuries. Scalp, maybe close, contusion, or open, puncture, laceration, and avulsion. You guys know what that is. And then obviously our skull fractures, open or close, linear, commuted, and the press, right? Press, linear, commuted, it doesn't have a form. Yes, am I going too fast? You guys have any questions? Yes or good? All right. Also, might have an accent and fuck up a word here and there, so just let me know if you don't understand something that I'm saying. All right. I'm sorry, did I offend anybody? You good? All right, let's keep moving. All right, MOI, mechanism of injuries. Primary and secondary, right? Primary injury is going to be the energy transmitted at the time of the blast, at the time of the injury, right? Whatever is the offending agent, blunt trauma, blast, gunshot wound, whatever it is, right? That's your primary injury right there. Secondary injury, disturbance of brain and systematic psychological results from the traumatic event, right? Brain's going to reset, right? Obviously, it's going to move all your nerves in there. So primary and secondary injuries, know the difference between those two. And know this one. Hypotension and hypoxia are the 2 most acute and easily treatable mechanisms of secondary injury. Hypoxia and hypotension. The most common, acute, and easy treatable. For hypotension, IV, hypoxia, put them on oxygen. Right. Patient, what's up? Sure.
Easy way to think of primary and secondary is kind of like a car crash too. You have your initial injury of when you hit the dash, whatever else. The secondary is just going to be that bounce back effect or long-term damage, like concussions, right? People suffer then they have a long-term effect where their mental awareness is fucked up later on down the road.
All right. Patient assessment and triage. The most important assessment, the most important assessment is vital signs. For a head injury, the most important patient assessment is vital signs. It's fucking easy to see that, right? And next, I put nest in there. You can notice my accent in there. I meant to put next. Put the S instead of the X. Some Spanish in there for you. It's the level of consciousness, and you will know the level of consciousness, and here's why. We're gonna use the Glasgow Coma Scale. One of the questions may ask you this: a patient who is not responsive, that opened his eyes to your verbal command, but does not speak, what's his score in the Glasgow Coma Scale? Anybody know? 5. Let's say 5? Yeah, 5. Can you have a score of 0?
No.
The minimum score you can have is 3.
A rock reset.
Yeah, 1 for each of the sections. So they will put 0 in there. If you get this question, they will put a 0 in there. You can automatically remove that one out of there. You cannot have a 0. The minimum score is 1 for each section, 3 total. All right. Casualties with GC score of what can be most reversible with interior neurological management involving control of ICP, intracranial pressure, and preservation of cerebrospinal fluid. So some of these questions are test format, are confusing, right? Casualties in what GCS score, casualties with the GCS score of what can be the most reversible with interior neurosurgical management involving, those questions? Okay. Score, 6 to 8. Good to move on?
So these are the bullet points I have for that too that goes online with what he's saying. Indicates a poor prognosis is a GCS score of less than or equal to 5. And a GCS score of less than or equal to 9, which is the 6 to 8 range, indicates that the casualty may do well if managed appropriately.
All right. What adds urgency and implies the presence of unilateral space-occupying lesion with secondary brain shift? Immediate surgery may be indicated. Transportation to neurosurgical care should not be delayed for treatment of injuries that are not life-threatening. A single dilated or non-reactive pupil. That's how you know it's unilateral. Did we move on? How should management be directed during treatment of head injuries? Toward preventing secondary brain injuries. That's how you manage during treatment of head injuries. Monitoring of intracranial pressure is recommended for all patients with a GCS score of equal or less than 8, or patient undergoing intratumoral aeromedical evacuation wherein serial neurological examination is needed. In essence, it is an adjunct to a neurological examination. It makes sense, and here's why. They might give you this, or they might give you the score. So here's why. What happens when we have a head injury being medevac by air?
Pressure changes.
Altitude.
Pressure changes.
The external pressure changes. So
Yes.
The internal pressure change.
Right.
And 2, and you will have ice.
So when we have brain injury, brain trauma, we're worrying about the intracranial pressure. All right. And this is out of subject, but you also worry that with tension pneumothorax.
Mm-hmm.
When you provide somebody with a gunshot wound to the chest, you are doing a needle decompress every minute or so. Anyways, keep going. Mild hyperventilation to evacuate to of 30 to 35 millimeter of mercury only as a bridging maneuver. So, in treating head injuries, hyperventilation will be one of the treatments, but only as a bridging maneuver until other measures take effect. Like I said, you can go into the details of the treatment on the chapter. This is chapter 15. Or you can get familiarized just with the questions and the answers. That's what you're going to see. Who should undergo prompt head CT to reassess for need for surgical intervention? Any patient who develops intracranial hypertension or deteriorates clinically. True or false? The use of mannitol in hypovolemic or under-resuscitation patients will produce hypotension. True. Do not use mannitol in hypovolemic or under-resuscitated patient because it will produce hypotension. Now I've seen this question different. I thought I put it in my notes, but it's not. So we move on. Head injury. Under Road 2, what must be done in consultation with regional neurosurgeon if available? Indications for emergent exploration and damage control craniotomy. So some of the shock trauma platoons on Road 2, which is your Road 2, after the patient gets medevac, they can do some of this surgical interventions. But in this case, they will have to consult with the regional neurosurgeon, if available. Right. True or false? Burr holes alone are inadequate to treat acute hematomas. True. They are inadequate alone to treat acute hematomas. You're also going to need medication, mostly anticoagulants. Right? For the damage control craniotomy by the general surgeon, removal of the vitalized tissue should be referred to blank as long as bleeding can be controlled. The neurosurgeon, that's going to be a given. Some of the questions that they put in the exam are so obvious that you second guess yourself. Don't. If a question is obvious, go for the obvious answer. We do that on purpose. Alright, approach 2 blank is aimed at removal and devitalized brain and easily accessible foreign bodies. Easy. Penetrating injury with neurological changes. Shit. Alright. This is the last one for this chapter. Injuries that include the frontal sinus, anterior skull base, and orbital roof should undergo early repair, which include all of the following. Most likely, you're going to see this question. One of those options is not going to be in there, and it's going to say includes all of this, but, or except. And then, so if you know the answers, frontal sinus extension, cranioization of the frontal sinus, obstruction of the nasofrontal duct, and multilayer closure with pericranial fat fascia and autologous split thickness bone. And that's the end of that chapter. I have 2 more chapters to go. Do you guys want to break or you want to push? All right. Aeromedical evacuation. I'm going to give you some information. At the beginning, I'm going to give you the answers, and then I'm just going to present you the questions. I don't have the material in front of me, so don't ask me what was the answer because I didn't put it there. If you want to know the answer, I have the material. I can give it to you. But so just keep it to yourself. If you look them up, you'll learn more. It will stick with you. Anyways, let's push. Okay. There's several types. There's CASEVAC, MEDEVAC, and aeromedical evacuation. We're going to go through each one of them and the difference. Okay. So aeromedical evacuation generally utilizes the Air Force. You will see this. It's the only one that generally utilizes the U.S. Air Force wing craft to move sick or injured personnel within the theater, which is intra-theater, and between 2 different theaters, right, which is inter-theater, right. We used to go from Ramadi to TQ, which is all Tagadoon, to Kuwait, to Germany, or sometimes we'll skip some of those, but yeah. AE, aeromedical evacuation. It's the first one. The second one is, actually it's going to be 4. En route care. En route care, pretty easy definition, is the means of treatment initiated prior to evacuating and sustainment of the patient medical condition during evacuation. So from the moment I start taking care of a casualty, right, before I even do my turnover to medevac, that is already considered en route care. From treatment initiated prior to evacuation.
So to make that make sense to y'all, right? He mentioned being in a helo where there's different altitude changes and different things to the environment, right? So if this person has a potential for a tension pneumothorax or any of their symptoms getting worse because of the different environment they're going to be in, they have to take note of that so they can manage those symptoms while they're getting them the helo to the next Roll 2 facility. Does that make sense?
All right, moving on. Medical evacuation. Now check this one. It's timely, efficient movement and en route care provided by medical personnel to the wounded being evacuated from the battlefield to MTFs using medical equipment, vehicles, or aircraft. So the key word there is a medevac, which is medical. So it's medical personnel and medical equipment. And then you have your CASEVAC, which is just a movement of the casualty from point of injury to medical treatment facility. And there's no medical personnel. So, if I got a couple of Humvees picking up one of my guys because he got shot, and that combo has its own corpsman, right? Because QRF has its own corpsman. And I get him into the vehicle where he is, and he's now stabilized. Well, the patient was stable, but he's now taking it. Is that a CASEVAC or a medevac? Anybody else disagree with him? He said medevac. Anybody disagree with him? No?
Non-medical personnel.
Why is it a medevac versus a CASEVAC?
So it's not.
Yeah, it's a doc. There you go. All right. Nah, I'm trying to insult anybody's intelligence. Throwing out there. Okay. Now, here are your questions. If you want to send them this out, or if you want to write them down, or however you want. If you want to take pictures, I don't care. I'm not going to give you the answers to this. So, these are no shit recycled questions from the exam. So if they use this reference, you might see one of these questions, 2 of these questions, or all of them. These are recycled questions from the advancement exam. Request to transport patients via United States Air Force aeromedical AE. System must be validated by who? Can I move on?
Nope.
All right.
Okay.
Also, the answers are also recycled. That's like how the question will appear. That's how, maybe not in the same order, but those are the options they're going to give you. Anyways, for patients evacuated from Roll 2 MTFs or forward surgical teams, who determines the evacuation precedence for all patients requiring evacuation from that facility?
Ooh, I love this question.
And that's why you break out the computer. Just give me a thumbs up when you're ready. Alright, let's go one more. Okay, moving on. Aeromedical evacuation liaison team consists of a communication team made up of how many individuals? 1 to 2, 2 to 3, 3 to 5, 4 to 6.
These have 100% been on the test.
Yeah. And you know what they do with recycle questions? I mean, they can't ask anything like something new because it's the same freaking instruction.
That question before that, I would pay attention not only just to that answer to that question, but seeing who all is responsible for approving each of those requests. Because based on the situation, the individual that is identified to be responsible for that can be different. You'll see that when you're going through the chapter.
Moving on. All right. At aeromedical staging facilities, they can have up to how many beds? That question was in every exam that I took. The beds, not just for the aeromedical staging facilities, but for the
Hospital shit.
hospital sheds. So they're like beds. How many beds? And then you get confused.
The OR room, ward rooms. I think it's like 15 ward rooms and I think like 6 ORs or something like that.
Shit. I don't know. I don't know. I stopped studying a long time ago. Why do you think I didn't make chief and I made chief? 2 more years, man. On my way out. These guys have it, right? They got the wall.
They got it.
Yeah, look at that. Those are jump faces. Except that one. It looks old as fuck.
These are all HM1 selects in the room right now.
Alright, moving on. Yo. In relation to evacuation precedents, which category is described as a medical condition could deteriorate and patient cannot wait for routine AE? Urgent, immediate, routine, or priority?
I challenge y'all to look up the amount of hours for each of these two. That's a test question. Just see within how many hours for each of these precedents of categories you need to evacuate that patient.
I don't know, man, but the way this question is worded, I think I would probably, I would not go for routine. Patient cannot wait for routine AE. And
Definitely.
all right, moving on. Moving on. To ensure optimum care, communicate with physician on treatment with patient and plan moving forward within how many hours. That X was supposed to be lowercase, because that's Texas right there. Lowercase is treatment. But yeah, to ensure optimum care, communicate with physicians on treatments with patient and plan moving forward within how many hours? 6 to 12, 24 to 48, 12 to 24, and 4 to 8. Alright, moving on. Who is one of the only individual that can validate a request and make it a requirement? Ooh, yeah.
I like this one. I challenge y'all to, so I have additional things to challenge y'all. I challenge y'all to see what PMRC stands for and what's their responsibility.
Anybody know what PMRC stands for?
Which section is this? Air movement requirements.
Aeromedical evacuation, chapter 4 of the emergency ward surgery, 5th edition. But yeah.
That's what it is.
It's a patient movement.
I think it's requirements.
Alright, moving on. Which is considered a logistical event? A clearance, validation, resupply of a CASEVAC.
That is 100% a test question.
Moving on. Moving on. To activate CCAT, the patient must require aggressive fluid administration or has received more than how many units of blood products in the past how many hours? Yes, that's how the questions are in the test. They ask you 2 questions within a question, and then they give you the answers. 5 and 12, 5 and 24, 10 and 48, and 10 and 24.
So I have another hint for y'all for tests coming up too, right? So the Navy purposely makes bibs based off of stuff they want you to know for current times that we are having in the military, right? So the common thought right now, and why we have new tiers, teachable Cs, and everything else, is we're going to be sitting on our patients longer. So we have to be familiarized with how blood products work, how long it takes for each of these to get resupplied. So these are the type of stuff that I would probably put more emphasis on studying, because they want y'all to be up to speed on that if we're going to go into that combat environment and have to deal with that.
All right, thank you. Moving on. Which of the this is the last one for this chapter. Which of the following statements is not correct regarding humanitarian transport requests? I'm not gonna fucking read them. You can, you guys can see them? Yeah? Yeah, options? Alright. Okay, I'll read it. The process of arranging routine humanitarian evacuations out of theater can take more than 6 months. All evacuated children must have an attendant. Those needing military transport require Secretary of Defense designee status. Clearances only need to cover the patient. So, which one is not correct? Moving on?
No.
No.
I like these are the questions I made. I made like a 1,200 question document that I sent to everybody to achieve the name.
That's why I got
Oh yeah, that was mine.
that was 2. You do that?
Yeah, I did that.
That's fucking great.
So these are the questions I actually created. So I'm going to send it to y'all. I created a 1,200 question study guide that has all these on there, so that way it can challenge y'all to kind of go through. I'm going to add more questions for y'all this cycle.
Man, fucking awesome, bro. I wanted to fucking meet the guy who did that shit.
Yeah, that's me.
Well, tip my head off, man.
Thanks.
I mean, I don't. Like, if I were interested on moving next to the next step, I think that's a fucking perfect tool.
Mm-hmm.
But hey, it helped me to fucking, like, that's the first thing I did, like, when I was like, oh, fuck no. That's what I do for this. Okay, moving on. Moving on. You guys are good? Break a push. Push. Last chapter. Okay? We got less than 10 more slides to go. Yes, chapter 9, soft tissue and open joint injuries. The goal and treatment of soft tissue wounds are, save lives, preserve function, minimize morbidity, and prevent infection, right? Through early and aggressive surgical wound care for far forward on the battlefield. So, keep that in mind. Moving on. True or false, antibiotics are not a replacement for surgical treatment. True. I put it in that way for a specific reason. Primarily surgical wound care. It includes all that. Limited longitudinal incisions, excision of foreign material in individualized tissue, right? Irrigation. Right, you cut, you make the wound a little bit bigger so you can go around. You remove carefully and clean foreign bodies. Then you irrigate, most likely with some kind of saline solution. Leave wound open, no primary closure. Antibiotics and tetanus prophylaxis. And splint for transportation. Improves with pain control. The less it moves around, the less it'll get stimulated and die. I mean, it's gonna hurt. You got open skin, but minimize pain. Anyways, know the following. Removal of dead muscle is important to prevent infection. Accurate initial assessment of muscle viability is difficult. Tissue sparing debridement is acceptable if follow-on wound surgery will occur within 24 hours. That makes sense. You don't want to be going exploring around the wound if you know that surgery is going to be taking more than 24 hours, right? you might cause some damage. Anyways, more aggressive debridement is required if subsequent surgery will be delayed for more than 24 hours. So that happens. Then it tells you, hey, the surgery is going to be tonight. You start debriding that. Hey, it's not going to be until tomorrow, so it's going to be more than 24 hours. Give it a second go.
So a bullet point that's not on the slide that you guys need to know too is a complete fasciotomy should be performed for compartment syndrome. You need to know that.
All right, the 4 C's. Color, contraction, consistency, and circulation may be unreliable for initial assessment of muscle viability. True, it may be unreliable, but it's a good tool to have. They use it, but not for initial assessment. Anyways, true or false? During primary surgical wound care, primary repair of nerves and tendons is not performed. True, it's not during the primary surgical wound care. You're not going to be repairing nerves or tendons, right? You're going to be doing more of the debris, more of the cleaning, irrigation, taking care of the wound. Repair comes during surgery. Cavitary wound may be gently packed with gauze to serve as wick for fluid egress. Excuse me. What prevents wound drainage and creates an anaerobic environment? Plugging the wound with packing. You guys know the difference between packing and plugging, right? So don't get offended, but think about a plug like, you know how in the past people thought that using tampons for gunshot wounds was a good idea? It's not. It's not. I mean, all you're doing is plugging the hole, but it will continue to bleed internally, right? I mean, are you providing any hemostatic agent to control the bleeding? No. You just plug in the outside without not caring about the inside. So if you ever heard that carry tampons on your med bag or do that, no. Anyways, moving on. That's plugging. Consider blank for high index of suspicious and limited capacity for serial examination. What he was talking about. Prophylactic fasciotomy. You know what prophylactic is, which is prevention, just in case of. So it's okay. So if you have a high index of suspicion and limited capacity for examination, and you trust me, you will know if somebody develops compartment syndrome. Shit looks obvious. Last slide. Okay, fasciotomy technique. Use full-length incisions to ensure that skin and subcutaneous tissue do not constrict the underlying muscle tissue. Keep fasciotomy wounds covered with moist dressing or an NPWT device. I don't know what an NPWT device is, so don't ask me. GTS, Google that shit. Do not use closure approximation techniques during the initial fasciotomy is being transported. This may be appropriate to consider if the patient is not transported and can be adequately monitored. So if you have an imminent medevac, casevac, or whatever vac, I wouldn't.
I have another test question for y'all. So just look up. Combat extremity injuries are at an elevated risk of developing compartment syndrome within how many hours of post-injury? Look that one up. Correct.
Guys got that. All right, so that's the end of me today. You guys good? All right. Good luck, guys.